now the next topic we're just going to see, this part is a little faster because we've laid the foundation very well all week long. We've been together. This is day 6, guys. So I'm on page 66 of your workbook. So page 60 here. Is that on the screen? Yeah, page 66. And we're talking about SVT. Remember in day 4 in the bonus round, I talked more about it. I even explained, for instance, let's say you take something like SVT. I said there are different ways you could treat it. One of them, number one, we could do a vagal maneuver, a Valsalva maneuver. For instance, what we're trying to do is activate cranial nerve 10, the vagus nerve, to activate the parasympathetic nervous system so that we can actually stop depolarization and slow down the heart rate that way. But of course, we need to tie in things like baroreceptors to fully understand a vagal maneuver. And I go through that in great detail in Level Up Medicl Mastermind, for instance, in the biochemistry part, biochemistry and the cardio part. The second way we can hit this is with adenosine. Okay, remember in the day 4 bonus, I also talked about adenosine. I broke adenosine down. For instance, we took adenine from DNA, we added some sugar on it. When you put those together, that's now called adenosine. So, and we said that adenosine, for instance, is a purine nucleoside, but it comes from adenine in DNA. And then I said if we take the adenosine and then we add phosphates to it with the help of what 2 things? What 2 things do we need anytime we add a phosphate? Of course, those 2, this is all review. Those 2 things were a kinase, which is an enzyme that causes phosphorylation. Whenever we add a phosphate, we need something called kinase, but we also need something called magnesium as a cofactor, right? This is all review. We've covered all of this already. And of course, that gives us ATP. I'm just tying a lot of things in for you. Now, the other way we said that we can treat SVT, if a vagal maneuver doesn't work, for instance, vagal maneuver doesn't work, adenosine doesn't work after, for instance, that second dose, assuming that you've given it properly. Remember, I said that adenosine, its job is to adenosine is naturally occurring. It's a vasodilator that helps with autoregulation to regulate blood pressure, for instance, right? When you're exercising and your blood pressure starts to go up because there's more sympathetic nervous system activation, adenosine is one of those things that gets released into the bloodstream to dilate your blood vessel, reduce the systemic vascular resistance to bring down your blood pressure so you don't stroke out when you're exercising. Well, we can also give that, for instance, an IV form with a flush, rapid IV push due to the short half-life and all of that. What's more important is that you know how it works. So, for instance, adenosine's job is we take um, eventually it gets broken down. Oh, ATP. So ATP, we said ATP gets broken down to cyclic ANP, and then eventually it goes to PKA. And what happens is we have calcium release, and then we have some other action, right? Well, that's what's happening in a tachyarrhythmia. The action is the heart rate is too fast. We've got too much depolarization happening. Adenosine is its job is to prevent this part from happening. But for instance, we said that caffeine could interfere with or inhibit adenosine, for instance. I've covered all of this, but here's what I want you to know. So those are ways that you're going to treat SVT. But now let's talk about what is SVT. Okay. So let's break it down for a moment. So SVT, so it stands for SVT. Let's write that in. SVT. It stands for supraventricular tachycardia. So obviously, by its name, we know that it's a tachycardic rhythm that is supraventricular. Well, what is supra? That means above. It means so it's a tachycardic rhythm that originates from above the ventricle. Well, if this is the ventricle, or these are the ventricles, what is above the ventricle? Above the ventricles are the atria. Okay? So another way to say this is just atrial tachycardia. Hang on just a second here. Okay. Siri was popping up on my iPad. All right, so So it's tachycardia that's often originating somewhere close to this AV node, but it's in the atria. Now, we've already talked about this. Somebody tell me, how do we figure out what's the difference between SVT? Like, when do we know to call this rhythm SVT versus sinus tachycardia? Remember, we've talked about this so many times. I said that you're going to use the maximum sinus rate. How do we calculate it? We take 220 minus the patient's age in years. So I said, for instance, we've used the example of an 80-year-old and a 30-year-old. We said 220 minus 80 for the 80-year-old gives us a maximum sinus rate of 140. Okay, so once they hit 141, it's called SVT for the 80-year-old. However, for the 30-year-old, we do 220 minus 30. That's going to give us 190. So for a 30-year-old, it's technically called SVT once we hit 191. Now, obviously, that's not good, because as this heart rate continues to go up, stroke volume goes down in order to maintain cardiac output. So what's happening is the faster the heart rate, the less blood that's actually getting pumped out with every single beat. That's why we're needing to slow the heart rate down. Just know that, I mean, so if you have a 30-year-old and their heart rate is 190, yes, you may call it sinus tachycardia as opposed to SVT, but you still need to do something about it. You still need to treat it, okay? And then there again, why? Ooh, I just said this. I said about SVT, for instance, how we use adenosine. And remember how I tied in going from pKa to calcium? Well, so ultimately what we're doing is preventing calcium. So let me draw, guys, I'm getting excited over here. So what normally should happen, or what is happening that's causing that fast heart rate, is more and more calcium is going into the cell. Adenosine is coming along to prevent that from happening. So you're preventing calcium from going into the cell. Another way to say that is you're blocking a calcium channel. What? So what would you call adenosine? That's right. You would call adenosine as a form of a calcium channel blocker. Does that make sense? Now, why do we use a drug like adenosine that's a calcium channel blocker for an atrial problem? Because we know that the two exceptions where calcium depolarizes the cell are, for instance, in the atria and the thalamus of the brain, right? Because calcium is the problem that causes atrial arrhythmias. This is why for every atrial problem, we generally use some type of calcium channel blocker, whether it's SVT, PSVT, whether it's AFib, whether it's AFib, whether it's A-flutter, whether it's wandering atrial pacemaker, multifocal atrial tachycardia, whether it's Wolff-Parkinson-White. So any of these situations, a calcium channel blocker may actually be indicated. Does that make sense? See how we tie all this in? All right, this is cool stuff. All right, so let me just clear some of this off the screen. Because I've covered a lot of this already in earlier sections, I'm not going to really add any more to the story there. Just make sure you understand what SVT is. Make sure you know the difference between SVT versus sinus tachycardia, and then make sure you know how to treat it, of course. And the reason we're having to treat it, there again, it all comes down to this basic formula of cardiac output. Okay? Cardiac output, of course, is normally it's about 5 to 6 liters per minute. So for instance, as blood is coming into the heart, the same amount of blood is leaving the heart to go throughout the body. But the amount that circulates within the heart every single minute is what we call cardiac output. Okay?